All right, so let's start the last session of today. So it's a pleasure to invite members of the Garbh-Ini. So the Garbh-Ini cohort is an interdisciplinary group for research in birth outcomes, and they've been putting together a very interesting data set and doing very interesting research. So since there are four of them, I'll just make it quick. Professor Shinjini Bhatnagar is a distinguished professor at THSTI. She's basically a pediatrician, but worked on a wide range of research topics with public health relevance, for example, diarrhea and so on, but broadly perinatal and neonatal and childhood diseases, I believe. She's previously in AIIMS, Delhi. Thiruvengadam was in THSTI until last year, and he's now in PIM Ponnusamy Institute of Medical Sciences. He's also a pediatrician with interests in basically neonatal and fetal development. Himanshu Sinha is he, I think, started off as a yeast biologist. He used to be in TIFR Bombay, and then he moved to IIT Madras, and he has interests in, I think, evolution, phylogenetics, as well as transcriptomics and data analysis and machine learning applied to a bunch of things, including this project. And Bapu Koundinya Raju has joined us online. He did his PhD, I believe, with Anurag Agarwal at IGIB in Delhi. And he's a Welcome DBT Early Career Fellow at THSTI. And I think I heard that he's also moving to Ashoka soon. And he's a physician with interests in, physiology interests. And, I don't know, was that correct? I think Anurag or somebody mentioned that. Okay, maybe that was wrong here. Or maybe that was like, anyway, so go ahead.
Good afternoon, everyone, and thank you for this opportunity. So, like Rahul said, I'm a pediatrician, and I grew up in a very tertiary hospital environment, trained in the national capital, and then went on to do my post-graduation at All India Institute of Medical Sciences. So, and also I did a PhD largely because when we used to be sitting in the clinic and seeing these patients, I don't know if there's any other pediatrician here other than Ram. What used to disturb us were those images of malnourished kids, even though we were hardcore pediatricians. And somehow we just felt that there had to be something more beyond what you're giving to them in a clinic. And fortunately for us, we met Professor M.K. Bhan, who was a professor of pediatrics at All India Institute of Medical Sciences and went on to be our mentor for life. Unfortunately, we lost him a couple of years back. So while we were doing this, there were a lot of work we did around diarrheal diseases. But as one grew and we managed to get some of these products into national policy, like ORS and zinc in treatment of diarrhea and a couple of other around childhood diarrheal diseases, what bothered us, and I'm saying us because we were always a group. I mean, I'm not going to take credit for this whole thing. It's been possible because we worked as a group. And it was the high neonatal infant mortality rate, which despite all economy booms and industrialization continues to be high. And so we started this program with a lot of support from, actually, it's a DBT funded program. It started in 2015. And the whole idea was that some of these adverse pregnancy outcomes are very ill understood. So you see the disease when it's already there. You see preterm birth when the baby is on the table in your hands, or you see a low birth weight or a small for gestational age when the outcome has happened. And the idea was to be able to predict these mothers, do a risk stratification of these mothers early in pregnancy, so that we could identify them and refer them for appropriate care. And if we are sitting in a tertiary hospital, at least manage them early enough. So along with this, one made a shift to Translational Health Science and Technology Institute, which for people who don't know, and we'd be very happy to introduce, this is an autonomous institute by the Department of Biotechnology, Government of India, and it's, as the word stands, translational. And our mandate is that whatever research we are doing should go into practice, policy, population, or at least there should be an attempt to do so. So we should be in the pipeline of doing that. And it's a cluster of other science institutes like the Regional Center for Biotechnology. And we also have a hospital which is going to come up in the next few years, but we began by collaborating with district hospitals. And that was my immersion in, it was a cultural shock for me from All India Institute to go to a district hospital and see what life was all about there. But I'm glad I did it and we all did it. So this program is part of a district hospital program where we are getting a semi-urban rural population for catering to this hospital. So it is not truly population, but it is representative of a population which is not so tertiary as one would be sitting in bigger hospitals. So the reason why we call it interdisciplinary is that when you're trying to study a disease, it's done in silos. You have the doctors looking at management, you have the various people who are looking at etiology, and there are people who are trying to study the pathways of mechanisms. So for preterm birth, which is our first adverse outcome that we have focused on. Now we moved on to a couple of more adverse outcomes. It's a very ill understood disease, largely because it's a syndrome, not a disease. It has a multifactorial etiology. The studies done till now have been cross-sectional. They have been just snapshot evaluations. There isn't much mechanistic inference available and very small size studies. So this big adventure we started in 2015, and as the name stands, we call it Garbh-Ini, as you can see the acronym. It's a collaboration between research institutes, tertiary hospitals, secondary hospitals, and the latest to join us is Himanshu, who I feel is as much a medical person now because of the immersion. So he actually talks about rupture of membranes and things as if it's part of the whole thing. So it's good to have a very multidisciplinary group on board. The objective is the whole mandate is epidemiological understanding of birth outcomes to inform clinical practice and policy. I'll just take a few minutes to explain about Garbh-Ini because I see a lot of young people who have approached us during the course of the day wanting to know how this data has been collected, how this data can be used for other questions which you may have around this disease or related diseases. So epi understanding of birth outcomes to inform clinical practice and policy, ultrasound and AI-driven tools for personalized prediction of birth outcomes, multi-omics biomarkers to provide customized clinical decision-making tools. So as you can see, the end is something that we can take back to the society. And it's immersed in Gurugram, Haryana in a district hospital. The target sample size is 12,000. Currently, we have 11,000 pregnant women that we have enrolled over the last 4.5 years. I'm not counting the first 8 months because that was the time we took to set up the cohort and everything. And we have what has emerged out of it. I'll just go through it very briefly because otherwise it'll take up all the time, is that we have a national biorepository now, which is emerged, which contains, of course, well-phenotyped biospecimens. We have almost 700,000 images and several thousand videos, and as 2 million well-phenotyped biospecimens in the whole of my phone. just ringing. Come from. Just switch it off. Yeah. So the conceptual framework, Ram. Yeah. So as I said, tools for early prediction and prevention of adverse pregnancy outcomes. I'll talk a little more about the biorepository and the data in a bit, just giving you a concept. So the whole idea is to get tools for early prediction and prevention of adverse pregnancy outcomes, which can come from epi and clinical risk factors, can come from ultrasound-based predictors and biomarker identification using multi-omics analysis. And also this multi-omics analysis would help us for pathway analysis, mechanistic inferences, and candidate interventions, which could feed into the tools for the whole outcome. So it has a diverse areas that we are looking at. So as I said, clinical and epi, we have a big probe around it. So it's all leading to the same thing, but because it's so big, we've had to divide it into several domains. We have nutrition, which is both maternal and fetal nutrition. We have multi-omics for spanning from genomics, proteomics, metabolomics, and we also have vaginal fluid, vaginal microbiome taken from first trimester across pregnancy, because this is a cohort. So it's not one cross section. All the data that we have is a longitudinal data set on the women through pregnancy at defined time points in their antenatal visits. A program on placental biology, which is a more recent one. And then, of course, we have on AI-driven tools, where we are looking at prediction of adverse outcomes using images, improving accuracy of dating using population-specific models, and then finally a dynamic prediction using all the data that we have to get one dynamic prediction algorithm. So the cohort, as it's, if you want more details, you can find it in the article we published. So as you can see, these are the various hospitals and institutes that are involved. This is Gurgaon Civil Hospital, where the clinical enrollment is happening. And like all other cohorts, we have across 7 visits, we're collecting clinical and epi data. So all this data is being collected. It's electronic end-to-end. We don't have any paper trails. We are collecting the data at the hospital, and it's being received at THSTI in the THSTI server. We, of course, have all our quality checks for this data in place. The biospecimens is up to 5. So we have a separate quality management team, which looks external team, which is looks into, does a data QC. And then we have biospecimens up to 5 visits, which are listed there, the kind of samples we have. And then, of course, what we are going to talk about today is the ultrasound images of 5 visits. So 4 visits, sorry. I don't know how many of you know, but district hospitals don't have ultrasounds. District hospitals, and Dr. Suresh, I don't know how in South, but North, if they have ultrasounds, they don't have radiologists. They are a prized catch, as we call them, because of the PNDT Act, you cannot get them. They have to register. They can only register on 2 machines. So why would they come to a district hospital when they have the opportunity of, and there's nothing against them because that's the way it is. And but we were able to set up this ultrasound facility. We have the best ultrasound machine there. The reason why I'm saying it, that the quality of images that we've got in our biorepository today is very high quality. And that is why I think moving forward, that becomes an advantage. And just one sec, Kara. Yeah. So up to 4 visits, I'm not going into it, but it goes from the early morphology to level 2 scan to a well baby scan. So we have all the fetal anthropometry, we have the maternal uterine structures and the placenta right through, pregnancy now. So at the moment, as I said, okay. So this is just a very short movie to just show you. So this is THSTI. And this is our institute, but this is the hospital where we are working, where the patients are enrolled for consent taking, all the maternal parameters are being taken, and all the anthropometry is standardized and as per harmonized protocols. And this is the biorepository that we have. So the specimens are transported to THSTI, all the quality scans are followed. And now we are going to be opening up the repository for the data as well as the biospecimens and the images, once provided the objectives of the Garbh-Ini are not compromised. So with that, so this is brief introduction. How did we get into AI? I think Anurag is partly responsible for it. And so Kondi is, who's there, is Tav's junior in his PhD, and he wanted to work, he's a medical doctor and wanted to work on ultrasound images. And he came by and he set up, he got the early career welcome grant and set up this whole system of AI images. And Ram, being the pediatrician and bringing in the clinical inputs, joined him. And then we had Himanshu, who came in with the data science strength. Just want to tell you that I'll hand over to Ram now, that it's good to be in AI, but it's not good to do AI without understanding the clinical research questions, without understanding the immersion of the model that you've taken out into actual practice. We're struggling, and I don't think our story is as successful as yours, Dr. Suresh. We're still starting, but we are learning on the job, and it is a challenge, but I think it's interesting and needs to be done as an interdisciplinary group. So do reach out to people who can support your questions from different dimensions, and be magnanimous about sharing your ideas and sharing your data, because that's how you'll be able to get your answers. So with that, I'll hand over to Ram.
Thank you, ma'am. So I'll just run through a few basic things that we have been doing just to impress upon what things have to be kept in mind when we are focusing on images and ultrasound videos as the raw material for any of the answering any of these questions. So we actually, right from the beginning, we were fortunate to have Dr. Ashoka Khurana as our advisor from fetal medicine side. So we had put in a quality control, quality assurance program, which was a 3-tier program, one at the image level and as well as second one at the data level. For data level, it is for any of the clinical studies you would be already exposed to, which is we had an internal quality improvement team, and then we had quality control processes, which are mostly programmatic, set at the data management level, and at the analytical level, when statisticians come in, do the exploratory data analysis, make some histograms, bar charts, scatter plots, very basic stuff to pick up outliers and implausible values. So those things are fairly standardized now in clinical methods, in clinical research. When it comes to ultrasound, it was a challenge. So what we had done was the 3-tier basis. One is the tier 1, where the study radiologist herself or himself collect 3 images, they score their own images, and whichever image they score the best, they mark it as the best image. And from there, we collect all the further information, be it the measurements or be it the identity of the organ and so on. And second is at an expert level, we had 20% of images randomly picked every month and sent to people who every day do fetal scans, antenatal ultrasound scans. And they are asked to, they are given an Excel sheet where they are asked to score for a maximum of 7. So in all images that are scoring less than 5 are then reviewed by Dr. Khurana. And he gives a recommendation of whether those images are still salvageable in terms we can still use it for analysis, or they so poor that we need to check them out of the data set. So that is the 3 level. And we have seen that the number of images that are getting rejected going on, coming down. And County, would you want to go through this AI strategic framework? County had actually put this together. With that, I'll leave to County to have a look at it, and then we can go for the panel discussion.
Yeah, thanks, Ram. So basically, what we are doing with AI in antenatal ultrasound in Garbh-Ini is first thing is automating fetal measurements, and second thing is predicting adverse pregnancy outcomes. This slide shows the entire strategic framework. So for example, there are several models which you can call them as nested models. Imagine a software where you can just select the folder where all the images are present. All the images of antenatal scan taken by a radiologist are present in a folder for a particular patient. And once you select that folder, there are, so I am just explaining the lower part first, the bottom part. There is a model called view classification model, where it automatically reads all these images and identifies what is present in the image, what anatomy is present in the image, whether it is abdomen, femur, head, placenta, or cervix. And once we know which image is it, if it is an abdomen image, then the algorithm for biometry will be actually run on the image, and we get abdominal circumference. Let's say if it is a head image, the algorithm for gestational age will run on it, and we get the gestational age at the time of the scan using head image. We'll be explaining about this model just now in a bit. And also the models for biometry will be run on the same head image, and the head circumference, biparietal diameter, occipital frontal diameter will be automatically measured, and so on. So for placenta, there is some other. For cervix, we measure cervical length and probability of preterm birth. So it's like a complete suite of algorithms which can automate antenatal ultrasound. We just have to select the folder, and using all the images, you get a detailed report on what is the gestational age, what are the fetal biometry parameters, what is probability of adverse outcomes like preterm birth or small for gestational age, stillbirth, etc. So this is the entire vision, and we broke it down into several models. Like for example, first one is view classification model, second one is model for estimating gestational age, third one is model for estimating biometry, fourth one is models for predicting several outcomes, etc. And the top part is for estimating gestational age. We took another approach, which we'll be describing it later. So we took conventional biometry measurements like head circumference and BPD, OFD, all the biometry measurements mentioned here, and build a machine learning model to estimate gestational age. And Himanshu will be explaining the details later. So this is basically the overview of what we are doing with AI in the antenatal ultrasound in our cohort.
Sorry, I just wanted to clarify. Conventional biometry was measured by the operator, and in your AI model, it was measured by the
it is by two
automatically forms. Or by the operator there also.
So here it is by the machine. It is the final aim is to get a gestational age. We have two approaches. One where we use the image, get the biometry, and run the standard Hadlock formula or intergrowth formula or any other formula. The other is where we don't even go through that step. We directly use the image and then give it's kind of a regression model. It gives what is the gestational age directly. And County will speak about what it is actually looking at in the
We'll
image.
be describing the model.
So before we go into that, so we have planned the session for two projects. We will be discussing two set of results. The first question, which we started with Himanshu's team, was on, can we use routinely collected clinical demographic information, which traditionally an obstetrician would collect in our clinic or in his clinic, and see if we can give a prediction of preterm birth as an outcome. So that was the first one. So I will put the question to Himanshu as to how this emerged and how this evolved as a question, and what were specific challenges as a data science team when you entered into this.
So coming from East, before the data science part came in, was trying to learn the vocabulary. So I think the first and foremost challenge that a person coming from outside the field into clinical space is to learn the vocabulary, because that's what is the first step. Unless and until you understand what is the vocabulary, the question that the clinician is asking is just a moot point. So for us, for me and our team at IIT Madras was the first challenge, that what are they asking, right? When we did learn the common language, then came the point, like, so for a clinician, it might be all very common, but then came a point that, okay, you're describing a phenotype, which is preterm birth. Do we have the accuracy of data that we want to call a birth as preterm or not? And that's where I think the first challenge came. We had a lot of discussion back and forth. They were, as it was mentioned a couple of slides ago, the data quality at Garbh-Ini cohort is very good. So there was no doubt about that. The question came, can we use the data, that is like the socioeconomic data, the anthropometric data, the clinical data, as well as the ultrasound biometry data at that point, to estimate preterm birth? So the first step is, how do you even go about addressing that question? And that's when, through our discussions with them, came to, like, I knew what preterm birth was, but I had no idea that this was based on a formula that was developed in 1992 in a cohort of 350 Caucasian women in US. And we are the most populous country in the world, and we did not have a formula for us. So yeah.
Clarify for the non-clinicians here that when you do an ultrasound of a baby, you pick up the gestation based on a formula which is called the Hadlock formula. That's what he's talking about. So that formula has been fed into the ultrasounds, and that's how it comes about. So.
Yeah, so that's because that paper was by Hadlock, the name of the scientist, so it's called a Hadlock formula. So whether you take a first trimester dating or your second or third trimester dating, both are the Hadlock formula, and they're the ones that are embedded in the machine. So when you are trying to estimate that, is it a good representation of the populations that we have in India? And that was the first question that we wanted to address. And so through our discussion, as I said, it became very apparent that we might need to relook at that and ask, is Hadlock the best formula for us to go with to estimate gestational age? Because if you're not accurate in estimating the age, obviously your classification of term and preterm would be erroneous. And that's what we wanted to do first. And that's, I think, was the first challenge that we started.
So before going into discussing the results and methods, what methods we applied, what was the approaches, I had one question. Professor Bhatnagar started with the reasons behind going for a data science driven approaches for answering the original question of risk stratification for preterm birth. What made you think, why not traditional way of looking at it? Why did you focus? Why did you think data science is the way forward?
Ignorance, I think. I think it just emerged from a lot of discussion and surrounded by young people who were talking about AI and talking about data. But apart from that, I think we had very good quality data and we wanted to utilize it well using modern science. That was one of our first things. And second was this whole concern about whether we can apply it to an Indian population and use it appropriately. I mean, that was the reason. And then we had the fortune of having the KI grant, which was funded by DBT. And that's when Himanshu came and partnered with us. So I think going with that and keeping a watch on time, Ram, maybe we should start the...
Thank you, ma'am. So I'll just run through the first problem, which Himanshu said. So as I said, we started with the goal of predicting preterm birth using clinical socio-demographic characteristics. But then, as he said, when we started looking at it, first we were not even sure whether we were even predicting the right phenotype. And why? Because pregnancy dating is such a... Preterm birth is a funny entity in medicine where you classify or you define that outcome not based on a set of symptoms or not based on set of pathological features, but on a time scale, right? So you arbitrarily put a time scale, a knife at 37 and say all those who are less than 37 are abnormal preterms. Now, if right at the beginning, if your dating of pregnancy was wrong, wherever you are thinking that it is 37 may not be 37, it could be 34 or it could be 39. So it is apparent, very apparent that your gestational age assessment right at the beginning of the pregnancy or during the course of pregnancy needs to be accurate. So I'll just run through why this is important and where the field is currently and where different people are working towards improving it. The first one is, as I said before, that's the corner. Gestational age assessment is the cornerstone of pregnancy. If you need to put in an intervention, be it say screening for preeclampsia or screening for fetal anomalies, you need to know you can do it at a specific window. So today, in the midday, Dr. Suresh was talking about early morphology scans or the target scans, which are done at very specific windows. So even for those kind of diagnostic interventions and some therapeutic interventions like low dose aspirin and all, this timing is very important. The second is, if we are not very sure about how far along a pregnant woman has gone into pregnancy, you don't know when to deliver. So for timing of pregnancy, it's important. Similarly, when the baby is born and the baby is going to be given for a neonatal care, the neonatologist need to know what is the gestational age of the baby, because that is going to determine what treatment she or he is going to give to that baby. And from a research point of view, from an epidemiology point of view also, if we need to understand burden of early birth, we need to know the definition of preterm birth accurately. So it started, as you know, this is a very age-old problem, right? So dating pregnancy is a very age-old problem. So people started with using last menstrual period. And last menstrual period, you add 280 days from the first day of last menstrual period to determine when the baby is going to be, estimated date of delivery. And you have a Neglis rule, which is kind of a roundabout way of doing the same thing, which is adding 280 days. But clinically also, there were some methods, very predominantly the fundal height assessments, where depending on where the obstetrician is able to feel the top of the uterus, which is called the fundus, they can tell how far along she is in her pregnancy. Now, both of this have got their own challenges. The first challenge is last menstrual period is actually a very, subjective way of doing it, because you are asking a pregnant woman to remember, and it's not just a blame on the pregnant woman whether she remembers or not, but there are also a lot of physiological problems like contraceptive usage, irregular menstrual cycle due to multiple errors, which can make this assessment go wrong. And we also evaluated it quantitatively. So the first panel that you are seeing is how last menstrual period as compared to the ultrasound, which is the current gold standard of assessing gestational age. We are seeing that there is a 2.8 days overestimate by the last menstrual period in the first trimester, and it goes on to underestimate in the second trimester. So this is the global data. And even in Garbh-Ini, what we are seeing is there is a 3-day overestimate in first trimester. So definitely LMP, both from a conceptual point of view, from a logic point of view, as well as from the data, it is actually limited. And fundal height, again, it is very subjective. It requires a lot of training. It might look like a very simple thing, like putting up your arm and then saying this is where the fundus of the uterus is, but it's actually technically difficult. And more so if there are these problems. If the baby is growing small, then the fundal height will be small. And you will be calling it as low gestational age, but actually the baby is far along, right? And then if there is a multiple pregnancy, then the size is not reliable. And if there are other problems like thick abdominal wall, if the Leica around the baby is too high or too low, then again, this is going to make this method unreliable. So naturally, as time evolved, people started looking at this wonderful tool, which is antenatal ultrasound. And with antenatal ultrasound, there are different measures. For trimester 1, it is a crown rump length. It's a measurement from the top of the head to the bottom of the buttocks of the fetus. And it is done in the first trimester. And its error rate is plus or minus 5 to 7 days. And in second trimester, we have crown rump length becomes unreliable. And now we have different biometry measurements like femur length, abdominal circumference, head circumference, biparietal diameter, which is the horizontal diameter, and the occipitofrontal diameter, which is the vertical diameter. And that can go wrong by a maximum of 2 weeks, plus or minus 2 weeks in second trimester, and plus or minus even a month in third trimester. So now from...
Sorry, I have a question. How do you know? So I understood crown rump length is the gold standard. How do you estimate the error of the crown rump length? I mean, how do you know what is the true gestational age?
Yeah. So the ideal way of doing that is, so how Hadlock did it was by taking a clean set of population who have a reliable menstrual age, right? Who have a reliable menstrual age, which means they don't have any physiological or pathological reasons why this is wrong. And you start following a cohort preconceptually. So you actually document when the first day of the last menstrual period was. From there, you set up a gold standard and you model your crown rump length on that.
So the error of 5 to 7 days in CRL is actually bigger than what you were reporting in the previous slide, right? Which was like 3 days.
Yes. So in our data set, it was 3. And that brings to Dr. Suresh's point at IIT that even CRL measurement is, potentially can go wrong depending on the level of flexion. And that also needs to be standardized. So it is not like, it's not the foolproof way. It's not it's the currently available, the most accurate way of doing it. Other than if you know when the conception actually happened, which might be possible in vitro fertilization or ART methods. Other than that, this is the best way to moving forward. And now this becomes benchmark for having any model which you will have to develop. So even for first trimester model, so there are different formulae, and you can see almost all of these formulae were developed in Caucasian population, in European population, or not in an Indian population, except for intergrowth, which had Indian population as a representation. So then Himanshu will go through those models. And when you come to second and third trimester, first trimester still feels okay, we have CRL, it's doing well. But second and third trimester is worse off. In India, the latest NFHS data shows that nearly 30% of pregnant women go for their first antenatal visit after first trimester. And not all of them will have an access to ultrasound for their dating. It doesn't mean that they go for in the second trimester, doesn't mean that they are going to have a dating. So how do we address them? How do we give them a gestational age which is as accurate as if they had come in their first trimester? So that was one challenge that we took. And you can see as the pregnancy goes along from 20 weeks to 28 weeks to 34 weeks, you can see the error rate going up, irrespective of whatever measurement, biometry that you are using. The decent one is the transcerebellar diameter and femur length, which is lesser. But even then, as the pregnancy moves along, the error increases. So these were the first set of challenges we thought we will start. And there are reasons why these errors can influence the pregnancy outcomes. And that's the first set of data that Himanshu will present. The second way of dealing with this problem was a slight shift in our thought process. As long as you use any measurement, it is prone for being affected by fetal growth. So however you do in any population you want, if the baby size is small, you are going to estimate the gestational age small. So now the size, another way of looking at it, can we use a size independent way of assessing gestational age? So for that, if you give an image, the image not just gives the circumference of the head, it also contains some information about the content of the head in an ultrasound image. Can we use those patterns or those information to give a gestational age moving beyond just the size? Will that overcome this fetal growth problem? So that's the second approach. And there have been some people who are working on it. Today, County will be discussing about a model called the gauge model. So this is the second presentation that you will hear. I'll now hand it over to Himanshu to take us through.
Yeah, are there any questions before I begin? Is it?
Thanks, Ram. Thank you, Dr. Shinjini and Himanshu. So my question is, if you go back to the previous, slide that you were showing before, Do you think that in estimation of gestational age, it is possible to look at the relative, although these metrics are actually capturing the same in the more expert domain, domain-driven manner, but by looking at the relative metrics of growth, which are beyond these, which can be directly learned from images. So these are by experts, head circumference, biparietal diameter, and so on. But there would be also some other measures, metrics that experts have not thought about, but may be visible, or on the ultrasounds, they may be apparent. So can there be a data-driven approach to use these relative featureizations to estimate age, other than using domain-based features?
I think County can also tell, but one step towards that is what County is going to present as the gauge model, where we are not telling that we are just saying that use this image, but we don't tell the machine to do a measurement and do this algorithm, use this formula to estimate the gestational age. That's one step towards it. Maybe when County finishes, then shall we revisit that question?
Okay, great. So just I'll maybe address that question, because he's asking whether there would be a feature that we are not capturing that can be used to actually make it more accurate. So we'll come to that in a bit. Okay, so I'll talk about the first part of the AI strategic plan, which is to use ultrasound biometry, which is already measured by an expert. So we have that data, and I don't need to go into this again, because Ram has already explained, and this is what the CRL is, and this is what Dr. Suresh was saying. The flexion in the neck can change the CRL value, and therefore there can be an error in there. But at the moment, based on the experts, this is the gold standard. So the gold standard is the CRL measurement in the first trimester. So for us, the idea was, can we develop a first trimester model for Indian population now that we had Garbh-Ini data, and how does it perform vis-a-vis the Hadlock model, which is available on the ultrasound machine? And I won't go into too much detail here, but if you can see, we had about 3,500 pregnant women data, and we actually did a very precise exclusion criteria to remove any kind of noise that might have crept in, even though the data was very clean. So we excluded CRL, which was biologically implausible, gestational age, which was biologically implausible, and we were left with around 2,500 observations. And then in that, we actually had two data sets, sub data sets from the training, which were the clinically filtered, which is what the standard clinical parameters that might affect the gestation, the growth of the fetus, those were removed, those were taken separately, and that is called clinically filtered data set. And then one was the data scan approach, where we actually did a ML-based data clustering to figure out which of the data set is whether this was a cleaner data set. So obviously, clinically filtered data set had around 1,500 observation, and the DB scan had a lower number. Okay, so I won't go into too much detail of how we did it. It was sort of as a brute force polynomial model fitting, because there was only one parameter that we had to feature. We tested all the socioeconomic and other anthropometric values, features that we had, then they had no role in that. As you can see from there, these were the two top performing feature in both the cases, both the independent models with crown rump length. And unfortunately, or whatever you want to call it, the Hadlock model and the Garbh-Ini one, which is the top model, the error in estimating in the test data set, which is the unseen data set on which the training model was not used, is approximately same. And this is the formula. This is again a quadratic formula, but the error was almost the same. So we did not improve on the age, and there was a reason for it, because this is a single feature. And secondly, it's mostly at that stage, developmental cycles are happening, and maternal nutritional does not hopefully affect the growth as much as it does in late trimesters. What was only a solace for us was that when you try to estimate preterm birth using the form gestational age determined by the Garbh-Ini formula versus the gestational age determined by the Hadlock formula, there was a slight difference. So you can see the bottom two here in this panel here on the right side. Garbh-Ini is at the bottom. It is showing around 11.5%. Hadlock is showing around 16%, which was a huge difference. So there was some thing that Hadlock was overestimating and Garbh-Ini hopefully was accurately estimating. We did not know that at that time, but I think this was the only difference we could observe vis-a-vis how the formula was performing. So we left it at that because the formula essentially was giving the same amount of errors in both in the test case. So this was great, but not very exciting for us. And as Ram mentioned, in NHFS 5, majority, and this was published in 2021, you can take a look at that. But as Ram said, majority, like 30% of women come for the first antenatal care in their second trimester. So the major challenge was whether we can develop a formula which performs as well as the first trimester formula that we have developed, right? That is the major challenge. Now, as you know, second trimester, there are a lot more effect of the maternal nutrition on the fetal development. So we had that challenge, and I won't go into details. Again, these were the 5 features. These are all ultrasound features which are standardly measured in all clinics. Another one which we took was symphyofundal height, which was also measured, and we went on to develop formulae based on these 5-6 parameters. The advantage of a longitudinal cohort is that, as I said, you have the same women who were an ultrasound for the women were done in the first trimester, and now they are coming for the second ultrasound either in the second or the third trimester, right? Both points. So you can, as I said, first trimester is a gold standard, so you can take that as a gold standard and ask, can you develop a second trimester formula which performs as well as the gold standard? So we had a gold standard GA, and we knew when it was done, we could add the difference in weeks, which is between the first trimester scan or second or third trimester scan, and that will give us what will be the GA in the second trimester based on what will be the GA from the first trimester. So you have a date based on the GA in the first trimester, that is a gold standard. Then you develop a formula which accurately predicts the GA for the date on which the second trimester scan was done. And if the difference is small or minimal, that is more accurate. If the difference is large, that means there is some error in the estimation. Okay, so again, this is the flow chart. So this time we had a lot more women. So we started with 6,500 data points. We removed a lot of women. As I said, a lot of women don't come in their first trimester. So about 1/3 of the data set was gone. But ultimately we had a training set of 3,000 women and a test set of 1,400 women. And here, as I said, we had a lot more features that we could capture, and these were all the features. And this is coming to your point. Did we look at any other feature? Yes, we did look at many other features. But when we asked what is their importance in estimating gestational age, and lo and behold, only the 5 features that were the standard features came up as the only features that contribute to it. And these are femur length, the 2 diameters of the head perimeter, and the abdominal perimeter. And these were the ones that we ultimately took forward to develop the formula. Now, as this is an ML-AI meeting, what we did was can we apply ML to sort of develop a formula? And we did. And in the test set, actually it worked very well. You can see it. This was a random forest model, worked very well with the test set, and it accurately predicted. So this was very nice. However, we wanted to make sure that this was sort of generalizable model. So we had another cohort which we ran at CMC Vellore, which was for around 1,000 women. And we used that random forest model to predict the gestational age of this validation cohort, which we called the CMC Vellore was a validation cohort. And as you can see, it is overfitting because it was very poorly predicting the gestational age. So if in a test set, a random forest model was working fine, it was not working in its data set, which was being generated from a completely different population, which is in South India. So that was an eye opener for us. And we had to go back to the drawing board. Like, what do we do now? So one of the things we did, and with this we came across when we were looking more closely to the intergrowth paper, is that they used in another ML approach, which is called genetic algorithm, which is essentially evolution of a formula using genetic evolution principles. So you put in all the features, you put in all the modifications of the features like logs, power, square root, and all those things, and ask it to predict a formula which is most evolved, which means which is most accurate. And when we did that, this is the data from the test set using a formula that has been developed using the genetic algorithm. And as you can see, this is where the error rate should be. If it is here at 0, it should be very accurate. You can see Hadlock is underperforming, right? It is having a long tail towards the negative side, whereas the Garbh-Ini GA2 formula is evenly distributed at 0, which means Garbh-Ini formula was quite accurate compared to the Hadlock formula, which we already knew. So there was no surprise for us. This is in the test set. The question was, how will it perform in the validation set? So we first, before I go there, this is why Hadlock formula performs poorly. The late trimester data set. So this is the regression line. This is the data set of the women coming in the second trimester. This is the data set of the women coming early third trimester and late trimester. And you can see Hadlock actually just does not traverse this cluster of data points, which means it's really not regressing well in terms of what the Indian data is, whereas the Garbh-Ini formula does perform very well. Now, what is the case with the validation data set? Validation data set, again, as expected, Hadlock was poor and Garbh-Ini was still equally distributed across the two 0 data point. And this is the RMSE value. So you can see RMSE, which is root mean square error. Hadlock has a very high RMSE of 1.43. Garbh-Ini was 1.29, which is significant. Yeah. It's not up.
The previous one. So, third trimester, it's not the same fetus, right? You're not plotting growth. You're plotting gestational age in the third trimester of fetuses who have not been seen. So if you just took a third trimester ultrasound to get gestational age, the Hadlock formula performs poorly.
Yeah. So if you look at the two, sorry, I should have explained the axis. This is the gestational age predicted by the gold standard, which is using the CRL of the same fetus. And this is the gestational age of the predicted using the Hadlock formula, which is given here, which is what the published formula is.
I didn't understand the red line.
But it's...
Oh, sorry. You continue. Yeah.
So because you have put that trajectory, I was confused whether what is that red line?
I agree. That's misleading. That's not a trajectory per se. It is just to show that, demonstrate that the Hadlock data points, if you use that Hadlock regression line, which is just a regression line based on Hadlock, this line. It is just to demonstrate that the data points are on the other side. Yeah. No. Exactly. So it is just to demonstrate that our data points are falling below the regression line of the Hadlock regression.
No, it's not just a 45-degree line.
No.
Why not put a 45-degree line? That would make it clearer, right? Because if it's a good... No, still...
Yeah.
The way it is, it should not, it won't go, it doesn't go to 0, 0 at least, not in the way the formula is.
Initially, you said these are all longitudinal data, right?
Yes.
And so this means the first one and second one, are they connected with each other, or you said they are independent of each other?
They are the same women. These are, and these would be same. Some of the data points would be slightly different, but yeah.
But used as cross-sectional data.
Yes.
Independently as cross-sectional.
Third trimester. It's not, there's no growth in there. Yeah, exactly. Sorry. Yeah, to clarify. Yeah.
When you say gold standard CRL, that is as measured in the first trimester.
Yes.
And then you're.
Yeah,
yeah,
thus
okay, right.
I'm just adding the number of days based on
Okay.
the date of the scan. That's
Okay.
it.
And we can lay out the question here is that there has been a lot of discussion on the gold standard of CRL in the first trimester. Yes, and we were wondering when that will come
I
up.
strongly believe it.
Yeah, yeah. But in clinic, yes.
Yeah, that's the reality. That's why I always feel using the head circumference in the first trimester will be far, far more accurate because very few mistakes can be done in the head circumference in the first. And I've been saying this for 20 years now. That because CRL was used.
Maybe we can actually.
No, because, yeah, I think it's a very
prospective cohort for
important
that.
thing because you plot CRL against head circumference, you'll get excellent linear correlation. Very, very, very correlation because we've already done that before. So the reason why they're refusing to go away from CRL is that a lot of screening algorithms, everything has been based on CRL. So when I pitched this to the person who created all this, he said it's too big a problem, too big a work to again redo all the formulae for all the screening algorithms. So he says, you just keep quiet. we use CRL.
Maybe we can like look at it retrospectively.
I think certainly because you've got so much data.
Yeah,
you should.
That's a good point.
You should be the game changer saying the world that don't use CRL, use head circumference.
Sorry, we are taking up one of them.
Still did not get the third line. So you showed that your genetic algorithm evolved the model, but that's in polynomial terms
It's
also.
a polynomial model.
So how is the linear fit?
So even if you look at this is log E, right? Right. It's what it is this, then you transform the axis to make it linear, right? That's how it is done, right? It is, maybe we can discuss it later on, but it's still, yeah.
I'm still very lost here. You're saying the axes are not linear. I can't read the axis labels.
But look linear. So the polynomial model has to have a non-linear fit.
Can I clarify?
Where is oh yeah.
Hi. So yeah. So the polynomial model will be non-linear if we plot on the x-axis, if we plot the variables used for prediction, and if on the y-axis is gestational age, then it will be non-linear. But this is a plot with just predicted versus actual.
Yeah,
exactly.
And and somebody has pointed out, I think it's Rahul.
Yeah.
It is right. You are right. A 45-degree line would have been much more clearer. But yeah, this is just predicted versus actual. So that's why it is linear.
So I didn't understand the explanation of the red line still. What exactly is it?
So this is, so if I like each data point, so if I look at this data point, this is gestational age of 25 weeks based on the CRL value. This is this. And this is what the Garbh-Ini GA2 formula will predict that age based on the difference in the based on the biometry at the second trimester.
So, but why is it a straight line then? Because
okay, we'll come back to that. It's a straight line. I'll come back to you, right?
Got it. So
yeah.
what Coundy said probably, I think that
it's just a estimation. Yeah. It's not the curve of the polynomial.
So this is actually a 45-degree line. This is actually a 45-degree line.
Yeah.
But you are not seeing it diagonal to diagonal because the axes are different. If you see y-axis is starting around maybe 14.
Yeah.
And x-axis is starting around 10 maybe.
Yes.
So because the axes are different, you are not exactly seeing it from diagonal to diagonal.
Draw this parity plot,
0, okay, 0. So it is x is equal to y is what you're plotting.
Yeah.
Okay, good. Thank you.
Yes.
Okay. So as I was mentioning, obviously in the validation plot cohort, which was at CMC Vellore, again, the Hadlock was underperforming, whereas Garbh-Ini 2 was pretty accurate. And the advantage of this validation plot was that if you look at this data set, you have two clusters, one here, and the question can be asked, what is happening here in the between the two data points that are there? So what we wanted to do in the validation cohort is to actually get data across the whole spectrum from 22 weeks to 35 weeks. And this is what it is. So if you can see carefully now, Hadlock is again just traversing on the upper side of the distribution, whereas Garbh-Ini GA2 bisects the thing. So that is that was a confirmation that whatever you do, Hadlock will always have a larger error compared to any formula that you develop from the Indian data. Yes.
So if you go back to the previous slide, so the previous one, the Hadlock model. So if you just moved the Hadlock model downwards, which means introducing a bias in the model. So intercept, decreasing the intercept.
Yeah, it will probably be.
Would it be still as good as a Garbh-Ini GA2? And would that be an easier way to, I'm just guessing, if I just move this line to have a little.
Yeah, the whole process is essentially that, right?
Yeah.
We are using the same, we are using the same independent variable. It is just that we are moving the beta coefficients. It's essentially regression model.
So that could also change the slope. When you're
that's what I'm
following the
saying.
model,
Slight slope, yeah, slope and
what
intercept
I'm
will
saying
change.
It's essentially recalibrating.
What I'm saying is it just simply that Indian babies are
Generally
consistently smaller, and if we just introduce a smaller biased term, we get the same results.
Yeah, that's exactly what you're saying here, right? If you can.
That's what is
do that.
happening actually.
That's what's actually
we need
happening.
a complex model.
It is not a complex model.
The Garbh-Ini.
It's not a complex model. We just have not. It's just using the same terms. So only difference. So we are using head parameter and the femur length, right? These are the only two features that we are using.
Then the slopes may also change. What I'm saying is more parsimonious model would be you just change the bias and it still fits best. That
is true. So we will have to figure out whether it's just the change in the beat, like the coefficient that we have to do, or whether the slope wavers a lot when we validate it across multiple data sets.
And the bias won't be stable across the entire gestational age, right?
So no, actually I haven't shown the data here, but the reason we are confident it won't be the same because our Garbh-Ini model has the lowest error from 22 weeks to around 28 to 30 weeks. The error increases as you advance. Hadlock is higher variance across whole of the thing. So it is not just the coefficient that needs to be changed. So that's the point.
Why head circumference was not used in the Hadlock formula?
Yeah, the first line.
Yeah, only.
One of them got into, he made about 6 or 7 formulae. One of them got into practice, and he himself in the Lancet many years ago said it's almost 30 years since I did this formula with a very small number of women. It is time to change.
Yeah.
And especially in India, nobody wants to change from the Hadlock formula. They say, oh, it works very well for us. But nobody knows how formula works. Okay, the babies are delivered, that's it.
So we were going to bring out towards the end of the session, actually share with everyone how we have a meeting in Delhi where we've spoken to pediatrics, and everybody is actually eager to see data for
We can actually parallelly run this formula and see how prediction comes. So it'll be a good thing to do, definitely.
Okay.
Yeah, maybe.
It's really, really, really interesting because this has been my bugbear for 17 years since I think one of the reason why clinicians are also keen for a change is we are seeing a lot more pathology nowadays, including gestational diabetes, which changes the entire management and the growth trajectories. So we are making clinical decisions, important clinical decisions, when to deliver, when not to deliver, etc., based on this. So I think that's probably one of the reasons why we want the change, even though people like Dr. Suresh have mentioned it for a lot longer. My hunch is if you use any structurally sound parameter, which is less with less variation for ultrasound expertise, you're going to get a better estimate, right? So that's probably why the head circumference does very well.
The other reason probably is head circumference. There is a head sparing. Even in there is a fetal growth restriction and nutrition problem. It is relatively spared. So the formulae which are heavily focused on head circumference, they actually do well. But that conundrum is not solved, right?
Yeah.
As long as you keep using any measurement of size, you have this conundrum. And that is actually a very good segue if we can ask County to go through the
just
model.
quickly, last 2 slides. Okay. So again, the advantage of using the Garbh-Ini formula vis-a-vis Hadlock formula is actually here. So if you look at the preterm birth, just 2 minutes. I got a lot of introductions. So the test data set, if you look at the estimated preterm birth rate from Hadlock is around 22%, whereas if you look at the gold standard, which is based on CRL value, that's around 9%, and Garbh-Ini GA2 formula actually performs at around 11%. So this is the major advantage that you have vis-a-vis how you are classifying, and this is given very well here. A large proportion is in this sector. No, advantage in terms of classifying preterm births, right? Accurate. So if you look, this is where the Hadlock is miscalculating preterm birth, and this is what the Garbh-Ini GA2 formula does. So whatever the slope or the intercept change is there, that is actually making a change in the final outcome. Very quickly, last 2 slides. The other thing that we were very interested in doing is subclassifying preterm birth based on various fetal maternal features. And these are some of the features that we collect. And you can see some of the features actually distinguish preterm birth and full-term birth very significantly. Some of the features do not. And we are very interested in looking at these 2 features, which are given at the top, which are fetal distress and perisepsis. And if you look at that, you can actually start figuring out that fetal distress usually results in high percentage of NICU admissions, and perisepsis is almost 100%. And they have a very high degree of co-occurrence with placenta previa. So by doing these sub-classification, you can start figuring out what are the complex etiologies that come together to give a particular clinical outcome. And based on that, you can start classifying preterm births, which would be based on their NICU admissions or based on their fetal mortality and other things. And that's something that we are currently wrapping up to sort of complete the analysis. And I'll stop here, and I'll thanks obviously to Shinjini's whole group, Garbh-Ini and others. Yeah.
So again, sorry if it's a very fundamental question, but thus far we are trying to find a model, an estimation of gestational age which works for an Indian population.
Yes.
So that we get the timeline at which we are saying 34 and 37 weeks accurately, compared to using CRL estimation.
Compared to what the
CRL, an accurate CRL will estimate.
Yes.
Because we need something to estimate.
So if you consider CRL as a
gold standard, Garbh-Ini performs almost as well, just 2% difference.
Yes.
But the last bit that you put in, which is all these other parameters, are problems that can happen in pregnancy, which can result in preterm birth. So that's a
That's a completely
separate thing
separate.
that you're doing, right?
so-
So this,
That's why I
you
said
can't
absolute-
club this.
No,
yeah,
no,
you've,
no, no
you've
clubbing.
jumped a lot of
I
steps.
know,
So
I
I
jumped
just
the-
wanted to make sure that
Yes. Yeah.
they're not connected.
slides.
Okay, right. Thank you.
Two slides are not relevant to dating.
Okay,
So last two
thanks.
slides are just to show that preterm birth needs to be subclassified,
Subcategorized.
categorized
Hypergenic,
to,
spontaneous, what are all
exactly,
the possibilities? We
exactly.
are not predicting preterm birth yet.
this
We are
is
dating
used-
pregnancy,
that's
which
a
is
major
a
part.
very vital problem, and second trimester dating is very relevant. So I think it's, yeah. So
Exactly. Yeah, even in here, we had to.
Yeah, and we will, if we stick to time,
Yeah,
then
I'll stop
we
here.
will have some questions in the end about from everyone on how do we take it forward. We have some plan. Yeah.
Yes, sir. So the table on the left describes the features that were selected, right?
Yes.
So-
that were tested.
Okay, that were tested. Okay, so I mistook them to be, I wanted to ask, why were these features not used when,
So I've jumped a lot of slides. We tested every feature, every combination of the feature. The only thing that mattered was CRL. No other feature actually mattered at all. No. Yeah, it wasn't there. It wasn't. So that feature wasn't available. So I think we should do that. Yes.
Over to you, County. Share a screen now.
If you stop screen sharing.
Yes, I have.
Can you see my screen?
Can
Hello?
see it? We can see it.
Yeah. Thanks, Raman, Himanshu. I think there's a lot of background has been discussed. My job has become really easy. So I'll speak now about our model called Garbh-Ini ultrasound image-based gestational age estimator. And we use raw ultrasound images and not any measurements derived from image to do this gestational age estimation using AI. And why to use AI for GA estimation? So it has already been told that nearly 40% of women come in second and third trimester, and there is a lot of 35% around, at least in our cohort, prevalence of small for gestation age fetus. So the main reason is, where size is not equal to age. There are two reasons for that. One is ethnically our population are smaller. So that has been addressed by Himanshu's way of approach of taking the biometry and making population-based India-specific model. The second thing why fetuses can be smaller is because of abnormal growth. So if the abnormal growth is the concern, then we cannot rely on the biometry. So our hypothesis here is if we use convolutional neural networks, it's a kind of artificial intelligence algorithm directly on the images, and ask the computer to learn directly from the image instead of giving numerical inputs like head circumference or all these measurements. So we thought that the computer might learn subtle patterns from the image. So as been told earlier, the head image also consists of lot of brain anatomy and lot of patterns in not just head circumference. So probably the computer might learn from these fine patterns, subtle patterns, to estimate gestational age. And hopefully these patterns will be same in normal and abnormal babies, who are not growing normally. So that's what is the hypothesis, and we want to test this hypothesis. For first, so we have taken all participants enrolled in Garbh-Ini cohort, and we have taken participants only enrolled during first trimester and has CRL based dating in first trimester, and that is our gold standard. We have also excluded a group of people where the gestational age estimated from CRL and from LMP is greater than 1 week. To make sure that our gold standard is even more accurate, we have included this strict criteria. And finally, we have around 2,200 participants, and we have taken images of head, abdomen, and femur from these participants. So these participants have undergone 2 or 3 scans in this process at 18 to 20 weeks, 30 to 32 weeks, 34 to 35 weeks. So each one of them have different images at different time points. We also had collected retrospectively a data set from Dr. Ashok Khurana's clinic for external validation of this model. And the way we approach this problem is, so we have taken the ultrasonographic image and we pre-process the image and clean it of all these annotations. And our neural network is actually doing 2 things, not just estimating gestational age. It is identifying the head region in the image. So this is called a segmentation problem, and then also estimating gestational age. So here, why we are doing segmentation is just to make sure that our algorithm is focusing on head and not in any other irrelevant part in the image. So this is actually a bit technical workflow. This is a clean ultrasound image as input, and we have ResNet encoder here, and features are extracted. These features can be of anything. It can be, hopefully these are the fine features as I described earlier. That's our hypothesis, subtle features and not completely reliant on biometry. These features will be used by 2 heads. One is regression head, which actually predicts the gestational age. And the second one is decoder, which generates a predicted mask. So this mask is a mask of the head. So it is identifying the head in the image. And when we backpropagate, we combine these 2 errors as loss, and then we backpropagate so that it is actually learning both tasks at the same time. So the segmentation is not for measuring biometry or anything. It is just, to be clear, it is just to make sure that the algorithm is focusing on that particular region. And once we do this, we train this algorithm, and the results are like in internal validation data set, it's around 3 plus or minus 3 days. And in external set, plus or minus around 6 days. So this is a plot in internal validation data set comparing our model, Hadlock and intergrowth. As Himanshu has described how to interpret this plot earlier, it's the same plot. Our model is centered around 0 and also has less wide, it is less wider. So the error is less when compared to the other 2 models. So in fact, it is almost 40% and 35% accurate than widely used Hadlock and intergrowth models. So here on the external validation data set, the error is slightly high because our hypothesis is that we collected this data set retrospectively and the image resolution is less. They are low resolution images than we have in Garbh-Ini cohort. Probably that's one of the reasons. And it might happen. It might happen even when we are deploying this model elsewhere, when we are trying to use this model. So to prevent such kind of errors and erroneous predictions, we have actually developed a framework called conformal prediction framework. And what this essentially does is, for every new image, it compares that new image to the training data set. And if the new image is similar to the training data set in terms of resolution, in terms of anatomy, the standard plane and everything, then the algorithm goes ahead and gives prediction. Otherwise, it asks for another image, more suitable image or high resolution image. So how we have done this is we took the training data set and we have extracted using the encoder all features, and all these feature vectors from all the images in the training data set, we have taken the mean. So we have this reference vector, feature vector. And for every test image, we also calculate the feature vector and we measure the distance between these 2 using Mahalanobis distance. If it is less than particular threshold, then we actually go ahead and predict the gestational age. Otherwise, it is rejected and we'll ask for new image. So this has been done for, actually to avoid erroneous predictions. So based on this, actually our algorithm is able to say, okay, this is your image. It might not be similar to what I have been trained on. So I'm not sure about this. I don't know. So this, the ability of algorithm saying I don't know is one of the novel things that we have done. So I'm just here showing in a bit more detail this Mahalanobis distance as we have measured in the test set, and we have transformed it to achieve normal distribution. And there is a mean and standard deviation in the normal distribution, and all those images with mean plus or minus plus 2 standard deviations, we reject them and ask for the new image. So why Mahalanobis distance? Why not any other distance? We have actually tried a few distances, but we have actually seen very good correlation between the transformed Mahalanobis distance with absolute difference in the GA. Absolute difference between true and predicted gestational age, which is the error. So as you can see, the transformed Mahalanobis distance and error are very much correlated. So it makes sense to use this particular distance metric. So after this, and these are the results with, using the conformal prediction algorithm and without using conformal prediction algorithm, as you can see in both internal and external, especially on external data set, the accuracy has been improved a lot. So coming for the start, I said the hypothesis is that our model might be learning subtle patterns and not completely reliant on fetal biometry. To see that, we have actually made activation maps, and in the activation maps, you can see here the region which is highlighted. So by the way, these are not very accurate, and we cannot interpret them directly as I am saying, but the broad interpretation is like the entire head circumference is not highlighted. Rather, some areas within the head are highlighted in most of the images that we have seen. So this gave us the hint that our hypothesis might be right. And we have also performed experiments like we have blurred the images and seen how the performance of the model decreases. Here it is error. The error is increasing as we are increasing the blur of the image. Here also, if we are resizing the image, make it low resolution image, also the error is increasing. And this sounds, obvious. If we are blurring or making resolution smaller, the error might increase, but this is actual quantification of the same thing. And it also supports our hypothesis that on the external data set, the error is little higher because they are low resolution images. Probably it might be due to that. And also the most important finding, the clinically very relevant finding is that our gauge model performs consistently in both small for gestational age and appropriate for gestational age groups. As you can see in this chart, the gauge model is the only model who is exactly same, performing exactly in the same manner in both these groups, while Hadlock and Intergrowth are overestimating gestational age, underestimating gestational age in the small for gestational age group. So with this, we conclude that this gauge model might be a better choice in populations where SGA is more prevalent, or similar models. Some models using raw images and AI might actually overcome these kind of limitations that we are discussing previously as well. So with this, I'll stop. I'll just show you a quick demo of the tool we have built. If any clinicians want to use our partners, collaborators, they can use this tool and see even in prospective validation studies we are trying to conduct. So if we select the view, upload an image and select the view, it says the view is head, and if you select gestational age, it identifies the head exactly and gives the gestation. So with this, I'll stop here. Thank you.
When there's a small for gestational age baby, the head circumference is smaller, but the brain architecture is the same, right? But the overall volume of the brain goes down also because the volume, but the pattern of the brain is small, which means your sulcation pattern, gyration pattern, whatever it is, has sort of matured. So that's I think it's a novel idea, really.
Okay, so this is just more a comment. It's not a question. Because you showed the what difference both blurring or rather both blurring and magnification can make to your prediction. Most of the other, similar image-based prediction models, they actually put a guidance on how that image should be taken to optimize your algorithm. So going forward, you may want to say that this image, this should fill the screen. You need, so it's actually good that, if you have in your test model where the performance is not so good and you have this degree of blurring, whatever, you can say that this model will perform optimally if the head circumference is, if the BPD plane is measured with ABC criteria. And you can look up whether it is NT measurement or any of the standard ultrasound risk prediction, or even cervical length for that matter. There is a very, very clear guidance on how cervical length has to be measured for it to be predictive of preterm labor. So I think that's just something, if you haven't already thought about, I thought I'll just say it. Thank you.
Yeah, thank you. So going forward, that was the plan. So why we have actually done these experiments is to confirm our hypothesis that on the external data set, the error is because of low resolution images and not because of lack of generalizability of the model. Just to confirm that, we have done these experiments, but going forward, yeah, exactly. As you said, we need to have clear guidelines on how to acquire the image and how, in which plane to acquire. More than 50% of the image should be occupied by head. All those criteria should be there. Yes. Thank you.
And this also brings to what Suresh sir was telling in the morning. He demonstrated, unless we correct the plane is right, it won't freeze by itself. So that is something this conformal prediction can be used as a tool. So you now tell the machine, and the machine is telling that I can't give you any number based on what you have given me. So it's kind of a quality check where it puts in, like you take an Adobe scan. The scanner will say that I won't give you a PDF because it's not properly captured.
So my question was, when you are estimating something and you're uncertain about your thing, instead of having a single formula, you can also have a confidence bound, right? I don't see any confidence bounds in any of your graphs.
So we have confidence intervals for MAE when I showed. I'm not sure I understand your question. Yeah.
Yeah, so I think for example, blurring, things like blurring, that is sort of encoded in the, no, I think, see, this MAE is for the entire test. So you're predicting one number. So instead of predicting one number, you predict your age and also tell me what is how you're calculating confidence interval for that particular prediction. This is over the entire data set, right? This is a different thing. This is not confidence interval.
He is asking.
Yeah, so I understand. So you are saying that we need to give confidence interval for each and every participant. Yeah, that is possible, but we are not doing that here. These are, so there are broadly two group of algorithms, right? They're deterministic and probabilistic. So if we use probabilistic models like Bayesian models, we can actually give confidence interval for exactly each person. We can actually predict them. So for our model, we don't have confidence interval for each person, but overall on the data set on an average, there is error of plus or minus 3 days. So given a prediction for any one participant, it has to be taken like it has an overall average error of plus or minus 3 days. But to give the exact confidence interval, we need to look at probably different modeling method.
Can I ask a question? Thanks, County. Very nice work. So
Thank you, sir.
I'm just trying to understand. So you applied ResNet model and the last demo that you showed with the head, right? So it's very interesting that
Yeah.
the model is able to have some internal sort of calibration metrics where it is for, I'm not sure if it is calcification or whatever, just by looking at the section of the head, it is estimating the age. I was thinking initially that we would probably look at the whole body and the relative changes of development in the body and basically look at. So do you have a sense of what might be working here? Although I know it's a deep learning model. So, but what might be working here?
Yeah. So see, clinically, anatomically, I cannot describe that. Might be looking at gyre sulci patterns or something like that. But with our experiments on blurring and all these things, I'm sure it is looking beyond biometry and probably looking at finer details in the head. But other than that, it is very difficult to exactly pinpoint that it is looking at something. And I also have something to add for your previous comment that you are saying that you will look at on entire body and all. So we also are developing, I mean, it's already, the model is there. So we'll talk about this caliper study later. So in that caliper study, what we are doing is we are capturing the video. So we are just capturing this sweep video. So we also have developed gestational age estimation model using that video. So you put the probe near pelvis, pubic symphysis, and just sweep up till the umbilicus, and you collect the entire video of the fetus. And using that entire video clip, we have developed gestational age models those are also very accurate. So that experiment also, I think, we are doing right now. So that tool is actually can be used by non-experts. You need not be expert in sonology, but you can just collect video from pubic symphysis to umbilicus, and then it can be interpreted and gestational age can be given. So that's another solution we are also working on.
Great, thank you.
I had a question regarding the attention map that you showed. I don't know if I sort of misunderstood it. Maybe slide 12.
Yeah.
There seems to be a orange blob vertically, right? Also, second blob.
Yes.
Using the height of the image to do some predictions or something like, I don't know.
No, I don't think it's height of the image, but I also observed it. I'm not sure what this one is, the left side of the image, but it is there for some images. It is not there for other images. I'm not quite sure of what it is doing. So actually, that's why I also told that while presenting these attention maps, it is not very accurate. It is just we are just projecting the weights back onto the image. It's not black or white 100% way of saying that only these pixels are contributing, only this region is contributing to the image, but it gives a overall idea. So that's why I didn't bother looking deeper into this part, the left part.
I have a more fundamental question. Your exclusion and inclusion criteria. Did I see BMI of 25 in what you presented? Sorry.
It was done for the first trimester model. In first trimester model, we wanted to take those women who have a reliable menstrual age for gold standard. For that, we had taken out all.
But you're using CRL, right? So
even before that, we started with redoing the CRL based model.
Only for that. So for these models, you have not excluded BMI because then it will be irrelevant to a majority of our population. Okay, thank you.
It's a question to Dr. Suresh, really. So when you see the head in that young fetus, is there enough differentiation between the bony part and the sutures and the gaps and the gap between the brain and the bone, or am I imagining too many things?
In the current day ultrasound machines, we certainly can get the skull outline will come out extremely well. The interface between the skull and the brain will be very well marked, no doubt about it. And above the skull, the skin line also will come out very well. And this is in a machine which is of higher quality. If you go to portable machines, then this granularity will come down, but still the skull and the brain interface will always be seen. Because sutures are something which you will never get the sutures in the axial plane.
Yeah.
You will only see the suture as a sort of a gap in the skull, that's all. Because the suture goes like this and we take it like that.
Okay.
So you'll see only a small little gap between the bones.
Okay. If the clarity of the image is what Gautam is saying, one of the reasons why the models have the variation, I'm just wondering whether it is not the bony parts, but the other things surrounding the bony parts will give that a fine tuning of that estimate.
Yeah, actually, the one thing I was seeing that picture with the color, the thing just there, the visualization of the parts of the brain is better away from the probe than closer to the probe. The parts closer to the probe will always have reverberation artifacts, and the part away from the probe, you'll have much better visualization of the brain structures. So that's why I was a little concerned when I saw the band which, on top rather than at the bottom, on the other side of the fox. Because it's a well-known thing that, in fact, it is a thing for my diagnosis that if the near part of the brain is not seen well, then the mineralization of the skull is good. In Australians imperfecta, the near part will be seen very well. So when the near part is seen well, I'm always worried about that baby. When the near part is not seen, I'm very happy that it is because the reverberation artifacts will come and do that consistently. You'll see it in all babies, in all machines, even at the highest level. So that is just a point to see features wise. Beyond the fox, you'll get features much, much better than the in front of the fox. No, sir. This is reverberation is between the skull. See, what happens is when the ultrasound beam hits the skull and comes back to the transducer, there is a total internal reflection between them. And that translates into the skull reverberations go down. And you will see, you go back on your images and see, just see what happens in front and back. You'll see always the posterior portions are much, much better.
Okay, so thanks, Koundinya.
I'm just saying that,
Thank you.
Rahul, we have another very important presentation, which is beyond dating, because
Yes.
we were told till 6 o'clock.
Right.
But do people want a 5-minute break, or is it okay?
I think it's okay. We had a coffee break already. Let's continue.
Okay.
Unless you want a break. Do you want a break?
What's he saying? No, we don't want a break.
Okay, let's continue then.
Okay, so the next session will be, it's a more work in progress. It's not very mature data, but it's actually a very interesting idea, and which Suresh sir in the morning, he actually referred to that idea a couple of times. So that's why that enthusiasm of talking to you about it. So one of the utilities of AI in antenatal ultrasound, sir was telling about triaging, like that's an important thing. And this question is on triaging high-risk pregnancy in the 3rd trimester. I'll run through the basic background, ma'am, and then County will give some of the initial results, and his results will be more not on results, but the approaches that we have taken and kind of getting a feedback from you people and what you think about those things. So we all know triaging in the third trimester is an important question clinically, because till anomaly scan, till anomaly scan, people are very well aware that there is a need for a very formal, very high quality ultrasound to pick up morphological problems. Third trimester brings in its own challenges. And Alfred Abu Hamad, he had published a paper. It was where he showed that there are some fixed sweeps that you can do on the abdomen of a pregnant woman. And those videos that are captured with those sweeps will contain information, will have sufficient information to tell about these very basic pregnancy related information. Why do we need to do an ultrasound sweep? So if we look at the challenge of doing a high quality, doing an ultrasound in a periphery, in a not skilled person, be it a medical officer or anyone, there are two challenges to it. One, as sir said, you have to navigate the probe. You have to navigate the probe to get to an ideal place, ideal plane, ideal frame, and then freeze it. That's one skill set. Second is, after you do it, there is some information on your screen. You have to interpret that from a medical point of view, physiological, anatomical point of view. So both these skill sets are difficult to master, right? So how do we overcome this? If we need to overcome these two barriers if you are going to give an ultrasound to a less skilled person in periphery, in a primary health center or somewhere. So two ways. One is you don't ask them to navigate. You just tell them, you don't need to look at the screen at all. There is no navigation. All you need to do is keep the probe in this angle, in this position, do these 5 sweeps, let the video be collected. You just master this skill of doing these 5 sweeps. Second, you don't ask them to look at the videos or images and tell what they are seeing. You ask the machine to tell instead of them. So, but you can't use these two to do a very formal expert level ultrasound. That is very unfair. But what can be done is, the challenge now we have taken is, can we use the same sweeps, some sweeps, and collect those videos and train a model or a machine to tell about these 5 essential features, like what is the fetal presentation, whether the baby's head is first or not. What about heartbeat? That's a difficult challenge. We'll come to it later. How many fetuses are there? Multiple pregnancy is a known risk factor. How many fetuses are there? Where is the placenta? Is it low-lying or is it normal? And is the amniotic fluid adequate or not? Can we even figure out these 5? It is not actually a very easy challenge. So from Abu Hamad's the 6-week protocol, the team, this is a collaborative work between THSTA and the University of Oxford. We started this work with Abu Hamad's sweeps, but we modified it according to the feedback that we are getting from the fetal medicine people as to what they are seeing in those sweeps in our pregnant women, and a modified protocol was established. The idea is, you ask the operator to do these sweeps. 5 steps. Step 1 is going to be like this. Step 2 is these 3 sweeps. Step 3 is this one. Step 4 is these sweeps, and step 5 is this sweep. For now, let's forget step 6. So if these 5 sweeps are not looking at the image, video, blind sweeps, and all these videos are then processed by a pregnancy risk algorithm, which will just at the end of the algorithm will figure out if any of these are present. Then we give a rule saying that if any of this is present, you call it as moderate risk. If 2 or more are present, you call it as high risk, right? Now for this was the whole idea behind this study. Now we started as a prospective observational study in Garbh-Ini platform. In Garbh-Ini platform, we were already doing these ultrasounds at these time points, 18 to 20, 30 to 32, 35 to 37. A full ultrasound by a trained fetal medicine person was being done, by a trained radiologist was being done. In addition, we asked them to collect these 5 sweeps or 6 sweeps. And now these sweeps were de-identified and all the identifiers were removed. And these videos when then given to radiologists to annotate what features they are seeing, and they were taken up for this one. At the end of we have a discussion on these ethical consideration, what challenges we faced when it came to data transfer protocol and all those things. That's a general question. This is the data flow. The videos were collected in Gurgaon Civil Hospital, taken to THSTA cloud, and then it went into THSTA data management center, all without human interference, because these are very sensitive videos, PCP and DT Act. So therefore we need to be very careful that there is no human who is accessing it. And then there is an annotation process. I think I'll leave from here to Koundi to talk about the annotation process and then briefly go on the results. Thank you, Koundi.
Hi, Ram. Can I share my screen? It'll be easier. Yeah, so the annotation process, as Ram has described, the videos are being transferred directly through cloud from the clinical site to THSTA server, where in the THSTA server, we have a separate workstation dedicated for annotation. And in the workstation, we have a tool called the CVAT tool. It is called Computer Vision Annotation Tool. It's an open source tool available on GitHub for everyone. So this tool, using this tool, you can do a lot of kinds of annotation. Like, as I have showed before, that we are identifying the head in the even gestational age model, that those annotations, everything can be done using this tool. And what we are doing is, the annotators who are radiologists, they have their own laptop. We have given a VPN account, VPN username, password to access to THSTA network. And then there is another security for the workstation itself to access these videos. These videos are not going anywhere out of THSTA. Their videos are in the workstation itself, and they are just accessing remotely the radiologists, and they were able to do the annotation. So next, I'll just show you the demonstration of how the CVAT tool looks like. This is the data annotation example. So this is the tool. You can freeze the video at every frame and identify the anatomy by drawing a box around it, and we can label it. So for example, this is spine, and you can adjust the box as well. And then if we click play button, the video moves along, and for each frame, we can draw the boxes around these anatomies and assign which box belongs to which anatomy. And if the anatomy is consistently present in 20 consecutive frames, if we just annotate first frame and last frame, it automatically interpolates in between those frames and identifies this anatomy, so that we need not annotate each and every frame in the video. So these kind of boxes we are annotating. And before coming to results, I just want to show some example of metrics and how to interpret the metrics when we are developing AI algorithm in the clinical context. So for most clinicians present here, you might have already known all these things. Apologies, but I just like to go through for the benefit of the other participants. So all of you might have seen this. It's called confusion matrix, like the test positive, test negative, test in the sense here in this case, if you are talking about AI model, we can say the predictions are positive, negative, and disease presents are absent. And we can have this, if both test and disease are positive, then it is true positives. And if test is positive, but disease is absent, it is false positive, and false negative and true negative similarly. So then now there are metrics called sensitivity, specificity, positive predictive value, and negative predictive value. So whenever we are building any model, we need to understand the clinical context, whether we are building this model, like, for example, for our Calipers study, we are building the model to screen for abnormal pregnancies. So we want to use that model on each and every pregnant woman coming to the clinic or in rural area. So it is a screening test, and some other test will be confirmatory test. So the sensitivity is used for screening tests. The high sensitive models will be used for screening tests. It is calculated as true positives by true positive plus false negative. It's like if n number of people are deceased, how many proportion of those deceased people will be captured by this test. And on the other hand, positive predictive value is if the test calls a person as positive, what are the chances that he is really a positive case or disease present? So generally, we are interested in the positive predictive value because we don't know the true status and we want to estimate that. If we apply our model and if the model says it is abnormal pregnancy and identifies it, what are the chances it is actually abnormal pregnancy? So that those are the chances that is the metric we want to know. So I'll just give just two examples for the same model. For example, in first scenario, if the sensitivity of the model is 0.8 and specificity is 0.5, 50%. And let's say here I tested 100 people and 20 of them have cancer. For example, just take a simple example. So then the prevalence becomes 20%. And since sensitivity is 0.8, out of this 20, 60 of them will be detected by our test and 4 of them will not be detected. Since specificity is 0.5, in the rest of the 80 people, 40 of them will be positive and 40 of them will be negative. So here, if I calculate our positive predictive value, it is very low. So it comes out to be 28. That means if I apply this model to anybody, and if the model says, okay, this person have cancer, there is only 28% chance that the person actually has cancer. And in the second scenario, the same model, same sensitivity, same specificity, but if I say 75 of them have cancer. So let's see, say this is a primary clinic and this is a referral clinic, oncologist clinic. So most of the patient who comes to oncology clinic tend to have cancer. Just by changing this number, you can see now out of this 75, 80% of them will be detected as positive. And out of the remaining 25, 12.5, which is, let's say 12, will be detected as positive. And now you can see the positive predictive value is very high. So even if the sensitivity specificity are the same, given the same model, when used in different clinical contexts, we can have entirely different results. So why I am saying all these things is, while we are building our models, we just have to keep this clinical context in mind, and we are actually fine-tuning our models to one of these metrics to achieve high sensitivity or high specificity while building these models. For example, first one is, I'll show you the example of breach study where we have fine-tuned the model to achieve high sensitivity in order to capture all the women with breach. So before that, we have this model. For example, I showed you the annotation process. The radiologists are drawing the boxes and identifying all these anatomies. And we have built an AI algorithm to actually do the same, do exactly what radiologists are doing, draw boxes and identify which anatomy is it. So here, the white box is the box drawn, predicted by the model, and colored boxes are boxes by radiologists. As you can see, if the box is there, it is pretty much accurate. But in certain other situations, it actually fails to identify the anatomy. But once it identifies the anatomy, the boxes are very accurate. So this is the model we are working with to the start. Once we identify these anatomies in these videos, using those anatomies, we are actually extracting the information. Some are rule-based classifiers, some are automated CNN-based classifiers on the number of fetuses presentation, heart rate, and other metrics that Ram has just mentioned. The first example is breach detection algorithm. So I'll just describe the methodology because it is interesting. And what we believe is that instead of just blindly applying these algorithms and automating everything, if we have a clear logic, clinical logic, and if we use that logic, we can actually get more generalizable and more accurate algorithms. And that's what we have done here. For example, there is a step one sweep, which Ram has showed earlier. It starts at the pubic symphysis in the pelvis and goes up along till umbilicus. So we have this video and we know that the probe position is here at the start of the video near pelvis, and by the end of the video, the probe position is near umbilicus. So using our previous model that I have shown you, the model has identified where the head is, where abdomen is, and where femur is in all the entire video. And the graph on the right side, the top graph, shows the probabilities of abdomen, femur, and skull. So in this first graph, on the x-axis, then it is a number of frames. On y-axis, it is probability of these three anatomies. So as you can see at the start of the video, for first 20 frames, the probability of skull is very high at the top, in the top plot. And the probability of femur and abdomen is negligible. But in the later part of video, the probability of femur and abdomen are very high. So this tells us that at the start of the video, there is head. So where is the start of the video? The start of the video is in pelvis. So we call this as cephalic presentation. In the same way, the bottom graph, you can see these are the frames of the video again, and this is the probability of these three structures. And you can see the head, the probability of head is present in the second part of the video, which is near umbilicus, and abdomen and femur were detected in the first part of the video, which is near pelvis. So this would be the breech presentation fetus. So with this sound logic, we have made this rule-based classifier. And although we optimized for sensitivity for this algorithm, but we actually achieved much better accuracy than expected because of the sound logic, as I mentioned. And it is very, very accurate. And these results are validation results on Indian dataset. This algorithm is developed by our collaborators at University of Oxford, Professor Allison's group. And we have validated the algorithm developed in UK in the Indian dataset, and these are the results in the Indian dataset. So the next example I'll show you is pelvis detection and masking. So we have been discussing about PNDT Act. We all know what that act is. And what we thought, why not use technology and AI to detect pelvis and mask it? So in order to prevent prenatal gender discrimination. This is just a proof of concept kind of work we are doing. So the research question is, as I said, can we use AI techniques to detect and mask pelvis region of the fetus? And we can incorporate these models into ultrasound machines. For example, portable machines are not, we are not able to use the portable ultrasounds in India. Maybe if they are equipped with these kind of technologies, one day, who knows, we might be able to get permissions to use these devices. So that is the basic thought. So here, as what we have designed as a pipeline is, as I mentioned earlier, for screening, you need highly sensitive models and then highly specific models for confirmation, right? So first we have this object detection model, the algorithm which identifies and draws the boxes like this that I have just showed. First we apply this model and see in what are the frames those consist of the pelvis. So here, not just pelvis, we are taking all the frames that has abdomen or femur or even pelvis is partly visible. So these are the rules that we have made. So by including all other frames in the video and not just pelvis frames, we are not missing any frame which has pelvis in it. So this is a highly sensitive step. The first step has high sensitivity. And after that, we are using segmentation model, which actually goes through these frames we have identified previously, and wherever pelvis is there, identifies and masks the pelvis, like make a bounding box around pelvis, like I have shown here. So this is a highly specific model and actually extracts the frames where only pelvis is present. So like that, while using first highly sensitive model and then highly specific model, we are able to, using these nested models, we are able to create a pipeline where we can successfully identify and mask the pelvis. So I'm not getting into technical details of what are the architectures we have used and all, but like we can discuss separately. This is just a demonstration of what we have had so far. This is maternal bladder in the pelvis. So slowly we can see the head, abdomen, and then pelvis starts appearing, and you can see it has been masked. So now we want to show this algorithm, use this algorithm and conduct validation studies, show these videos to expert sonographers and ask them if they can determine the gender before using this algorithm and after using this algorithm to actually evaluate the clinical utility. So we are in the process of doing that. So these are the few examples today I would like to share from our study. And if there are any questions, you can take.
Thanks. I didn't actually have a question.
The only concern about that pelvis thing is the normal anatomy also, if it is there, then we may miss some diagnosis, especially bladder. It's very important to see the bladder. And if suddenly comes, it says bladder, they're not there, then we get a bit concerned.
So, one answer to that is,
Yes.
this is definitely not for a fetal medicine clinic or a tertiary care hospital with all the PCP and DT Act. The idea is where we don't, say for example, gestational age assessment. We don't need to have fetal pelvis there for gestational age assessment. But then the tool, we are not able to get it to market because it potentially, exploitable. And that is where this idea of, can we put in an additional technological, in addition to the legal procedure?
My suggestion will be, instead of making that mask, why can't the image itself be blurred? So I will still see the outline of the bladder. I'm quite happy with that. The perineum being the image getting blurred, like we see in the television, they just see the faces getting blurred, no? So that may be better than a mask itself, I think.
So this is the feedback we got from some gynecologists in a Delhi meeting when we had spoken, and they had the same concern that will you end up missing some congenital abnormality or some other, and that will be quite a disaster. So we have
promptly will take us to the court.
Yeah.
That's
No, so this is, like he said, this is the beginning, and the reason why this was initiated was because we have to get the
as long as if this really works, then it is not getting the machines that's important. It's getting the number of doctors who can do the scan more. See, the fallout is very big, that the restrictions on doctors not being allowed to do scans is when the machine is not capable, then they can allow doctors to do scans, isn't it? So I look at it from that point of view, where enormous amount of manpower will be available to do scans, which is very, very important. Right now, there are very few people doing that. So that's where this becomes very vital in ensuring that some form, at least the government must be convinced that this will work. And it's very vital for India.
Yeah, so I have a question.
So
about
another.
Okay, continue, please.
No, another argument is that we can use portable ultrasounds for other disciplines out of obstetrics, right? For surgery, abdomen scan, or echo. For all other disciplines, if those machines are incorporated with this algorithm, it can prevent misuse, as well as that is also one more way to look at it, I would say.
So I've been hearing this for years, but especially at this meeting, that how terrible this PNSD Act is in terms of depriving hospitals and especially rural hospitals. And Dr. Suresh was actually saying even worse stories over here the other day. Why can't experts around the country, from people like you and Suresh Gaganipkang, Ashoka, everyone get together and really lobby the government? Is it completely futile to do that? Because this act was passed in 1994, a completely different government, and we are almost 30 years down from there. So,
Yeah, so we had this as a concluding. Okay, maybe you stop the recording. No, I'm being so very genuine concern, and I think all of you must be dealing with it. And so we thought the best way, the next step was that while we're working on these, we start interacting with stakeholders, getting a feedback from them as to how to go about it, because we all know that it's important and we feel that to move forward, this is critical. And so we've had a couple of meetings, and we've been doing some regional meetings, talking to the gynecologists, getting their feedback, and we're going to prepare a report. And hopefully all of us can, we can interact and get that report together and then move forward on that. The second is, I think once the validation happens and those papers get peer reviewed, and that also gives us a kind of evidence to move forward on these things.
Because we need a magic bullet for the PCPNTD Act to be set aside. This is the magic bullet.
Yeah, but
because that's the only problem. Nothing else is the issue except this.
No, but there was some news item very recently that the PNDT Act is going to be modified again.
Yes, they've been modified again. I was part of the first modification. We met 3 health secretaries. We have done everything what was possible, but their only contention is the sex ratio in the country is not getting altered. Now, after 20 years, if it's not getting altered, there is something else, isn't it? So we please get an AI algorithm to predict why sex determination is altered. That will solve the problem.
We had parked a few questions on, it's actually regarding this whole idea of how do we move forward in this. The first question is to you, what are the challenges in getting together even this diverse field of Allison on one side, the radiology team on the other side, and what were the challenges, and how do you think we all should move forward in getting this mix of clinicians, clinical researchers, and computational people together?
A meeting like this, I mean, Allison and I met in 2012 when we tried to put an education program together for a grant application. It never went through. So I think that made our resolve harder that we should talk. I think it's basically having more platforms like this. I think Condi discovered us on a platform like this only and came and said wanted to work. Similarly, I think so I think we just need more platforms for people to work. We also need more data for young investigators to work on, because unless they see it successful, they may not want to, it's not easy to do all this, and then you need support to do it. So I think those kind of platforms are important. And I must say that there has been, from the time we started, there has been much more enthusiasm on these. I think the challenges were largely just having a dialogue and learning the language, like Himanshu said.
And it is a question to you and as well as the seniors here. So how do we, most of the times computational people, County often says, they learn a programming method or a computational method using toy examples from, but when it actually comes to real world data set, which they don't have access, unless they come in collaboration or work with as an intern for measly money with a research group, then they learn what are the actual challenges in dealing with real world data set. And that's where the learning starts. So from seniors like you, and others, how do we get this get the computational people hands-on, more data sets, what systematically, programmatically, how do we share data sets, particularly sensitive things like ultrasound? Any ideas, Rahul, Suresh sir?
So I
Tav?
think,
Tav, do you have any feedback on that? You've been also working on this interface.
Opportunity is to perhaps create synthetic data sets. That may be one way forward, because we have to deal with this challenge of data sharing. That may be one roundabout way of doing that. But other than that, I think the bigger challenge is to actually get the, as you said also, to get the people trained at the interface, which should be addressed. I mean, even with synthetic data sets, the problem just doesn't go away, that we do not have enough number of people who understand the complexities of healthcare when we're doing modeling. So we have to build that cadre of people who basically understand both in a much more structured fashion, and we have to develop programs around that.
I just want to know from the younger people here, how many of you have had challenges of being able to get data to work on?
say,
Yeah, hello. I have not really worked on data from medical domain, but so I have dealt with energy consumption data from households at one point of time, basically got access to the raw data. And recently I have been working on wastewater data. The common challenges are basically a lot of these data sets are not in standard format. There is a lot of variability. For example, there are multiple sources also. So giving a recent example, for example, we got some wastewater data from different wards. Now, the way wards are there in BBMP, giving an example of Bangalore, they are listed in a different naming fashion. However, where the data is recorded, there the names are different. And if we want to get some extra information, side information from some other source to build some, let us say, some other sophistications, those namings will be different. So there are a lot of these things which are not in standard format. Now, if I refer back to the earlier data set that I was working on, which was electricity consumption, there we assume that data is getting recorded. Sensor is there, but it may not necessarily be recording the proper thing. There may be a lot of artifacts, there may be a lot of garbage. So those kind of things are there. I mean, from my understanding, and it can possibly be there in other data sets also.
So I think you're right. So there is a data policy, but what is, at least the funding agencies, DBT and all, are realizing that every PI has their own format of Excel sheet that they upload, right? So there is a framework called FAIR database, FAIR data, which is like findable, accessible, interpretable, and reusable. So from now on, at least for the DBT funded projects, they would ensure that this is the format that you follow. There would be a common dictionary, common terms, which would be there, which would allow. So I think some of the problems that you face may go away. I'm not sure whether it will go away immediately, but will go away. But at least the publicly available clinical data sets are somewhat more harmonized than municipal corporation databases.
So I just want to say, I mean, Nikki Tiffin has been talking about exactly this issue last week. And she commented that, 80% of her time is spent cleaning up the data. And in India, maybe it is 90-95%. But she talked about basically ontologies and systematization, and also, how to set up your own database, do's and don'ts. And one of the don'ts is don't use Excel.
Yeah, I wanted to say that.
Yeah,
Excels are extremely painful.
Among many other useful things. And regarding your point about DBT and standard ontology, I mean, it might, in bioinformatics, it's standard. In clinical data, maybe it's becoming standard.
It is becoming standard, yeah.
But in wastewater data, maybe there is no ontology. And if you're in a new field, somebody has to develop that. So it will be a very, challenging, long drawn thing. But maybe that's something we should all focus on. Yeah. Anybody else on data access? Yeah.
in response to that. So although the fair data, by definition, we want them to be fair. We did a study during the COVID time on COVID data sets that are getting deposited on with research, peer-reviewed publications on these fair portals. 1% is what maps to SNOMED CT. 200,000 data fields, only 1% actually are mapped to the SNOMED CT fair data sets, because that doesn't. So I think if you are actually talking to the DBT folks and also giving recommendations, I would recommend that there should be mechanisms where we also then start ensuring that, for example, drop-down menus with SNOMED CT terms to make that possible. Otherwise, it's easy to say that I'm depositing fair data set in this repository, but that's not the reality in the real world.
You tell me about it, because
I'm just saying that
I can give personally, like when you say to PIs in a consortium, this is the metadata that you have to report. A very, very small defined list. You ask them to give it back to you, half of the fields are empty. It's not that they haven't collected it, because we know they have collected it, it's just they're not reporting. So it is, I think, somehow has to be beaten into the system, but that is altogether a different challenge. So
we have developed a retrofitted pipeline to enable that, but I would say that's not the best way to go. The best way is actually something.
Yeah. Thank you.
There was somebody.
As a data scientist, I think the major challenge I have seen is, although the data sometimes not standardizable, or maybe it's a work that even machine learning can do to standardize something, but the major challenge I find is asking the right questions. Like sometimes, say for example, when the model I was seeing, there was a comment that the radiologist doesn't measure it accurately, but this part is measured accurately, so let's use that part. So that kind of inside information that like, say for example, even when I was working with medical data set, which value is more accurate, and like which clinician actually uses in the clinical setting. Some of them are empirical, so what part is empirical, so that machine learning engineers could understand that this is the area where somebody can come in and actually make a scientific query about how to change this empirical formula into something which we can understand. So I think it's more about like something which was discussed earlier, like around the conference we can collate and find out what are the real research questions which clinician actually want to ask, and find it plausible and can see it in future.
Need more meetings, more collaborations.
Definitely.
So,
Am I audible? Yeah, fine. So what I feel basically is one of the most challenging issues is that we do not need more machine learning engineers. We need more of the people who are trained in understanding the data. So if we train our people to understand the data only, 70% of the problem will be solved, because nowadays what happens is if you will look at some of the data, majority of the fields are not there, and people are not trained in the good direction, how to perform the surveys, how to collect the data, or even the data which is collected. The data is like a lot of anomalies will be there, and the people just do some mistakes, and just because they're getting the money to submit the data, and they will submit the data. So we should try to train people and the youth, because we need to focus on the youths, and they need to be trained in the direction where they understand the importance of the data and how to perform good surveys, and statistical importance, that this is where you need to get the data, and people should be able to realize the importance of prospective studies more as compared to the retrospective studies. So, yeah.
hello. Yeah. So I was able to attend Dr. Raghuram Rao's lecture, actually, one on tuberculosis modeling, in which he described data to follow 3 C's: completeness, comprehensiveness, and correctness. So that is where he mentioned that we need to have a lot of focus on. And even in one of the prior talks by Professor Anshul, so he had described two different classes of imbalanced data, 2-pointed. So even then, when I was asking how to modify data, he mentioned that we have to work on models, or the model cannot be worked on such data, indicating that the data needs to be more precise. And even as Alok mentioned, I'm learning all of these, and I'm trying to understand all of this actually. So this is actually giving me a sense that, as Alok just mentioned, it doesn't necessarily mean that we need more focus on the machine learning part of it, because we have many people who can understand and model or get some inference out of it. But unless, as even mentioned many times, garbage in, garbage out. So that's where the primary focus should be, is what I also feel.
In fact, hospital data, at least from the government institutions that we've worked with, it's very difficult to get data, which is, because whoever is recording the data, it's not possible for them to spend that kind of time. It needs a lot of time and rigor. And then the quality check of that data. I mean, we spend half our budget in just quality checking that data. So it's very important. And that's why we can confidently say, okay, may not get an answer, but at least it's a true.
It's the same with majority of the private sector also. It's there are of course there are many hospitals now which have the hospital information system and all that, but majority of the hospital information systems are oriented towards administration and billing rather than clinical information. So we are actually generating the data, but now not storing it anywhere. So that's why, and people who are interested in research by themselves may not be generating too much data, but those who are generating a lot of data have no time for research. So this disconnect is also there.
I don't think we need to be this pessimistic. It is a challenge. It is a challenge, and it is challenge that we can only resolve collectively. So if I could share some of the recent experiences and where the NHS is going and how NHS were able to pull together, especially COVID data on mortality. But that was only feasible when they introduced, that was in 2004 onwards, really, but it's really 2007 onwards, the data is systematically collected. But again, that's, there was an incentive for the primary care system to collect certain types of data in a systematic way. So the flip side of NHS is there are different data systems within the NHS. So that's where the challenge comes. So even some of our studies from 10 different sites will have 10 different fields if you are thinking of collecting real world data. The advantage is that we have the learning, and sometimes starting fresh with new digital data collection has the advantage to learn from other places so that you can minimize that time frame to get to it. So my other point is, Rahul, I think we have a very good point for our paper for the meeting, that this should be one of the strategies that we should collectively put forward for the government, that includes the scanning issue. And one other clinical problem we can't deal with in India, because we don't have a fetal sex. If we are using, we know that boys and girls grow differently, but if you are using some of the predictions, if we don't know the sex at the time of ultrasound images in first trimester, we can't really do much about it. So I think there may be more than one angle to push for this to happen? You don't think this is going to change?
So since you mentioned the position paper, I mean, we were discussing, possible outcomes of this meeting, and one was, we'll send a mail to all of you, but discuss what kind of both for the community and policy recommendations for the government, how to take this forward and write up something. So we'll be in touch about that.
Yeah.
And yes, these points are useful. I want to make a couple of comments about working with not just data scientists, but theoreticians and modelers generally. Like Himanshu said, you have to learn their language. But so I am a physicist by training, and I got into biology during my postdoc days, but that was computational molecular biology. And yes, you do have to learn the language, but I saw both in physics and in computer science. I mean, there are a lot of people who do biophysics or computational biology. There's one category where they are interested in the physics and they build their toy model, or they're interested in the computer science and they build a clever algorithm, but they don't push it all the way to apply it to a real biological problem. I mean, they get more interested in their model or their algorithm, and it's completely artificial. And then there is another kind who really works closely with the biologists and does really useful stuff. So for example, I think computer scientists have made a huge contribution to bioinformatics by applying algorithms like the Burrows-Wheeler transform and things to sequence analysis. And actually, some of my computer science colleagues are very fascinated that these things are actually being applied in the real world. But that kind of translation is still rare in India, even in this setup. In terms of data science and clinical data, I think a lot of the data is there. As Saurav was saying in a different context this morning, there are more data than people to analyze them in terms of, in his case, single cell RNA-seq. But I think it's true even of, you have a huge amount of data in Garbh-Ini, and you're probably, every hospital has data. Rajiv Raman was talking about Shankar Nethralaya has data going back, electronic data going back 15 years. We probably need to, of course, have a way to polish up and make the data accessible. And we talked about, issues with sharing human data and all that. And we have trained data scientists in increasing numbers around the country. I think if we figure out the interface, we can do a lot of things. But yeah, these are, yeah.
There is a move from funding agencies in India, DBT, ICMR, where they want to do questions in a mission mode. So if you have an outcome and you combine the data which has been collected across the country by different people, and maybe small size data, but you combine it together, because harmonization becomes a problem. But then they have said that one of the domains can be AI, for data science. So like you take stillbirth or any of those diseases, you have so much data in different areas, then you combine it and it becomes a large sample size and harmonize it and then let different domains use it. So that's, I think, a really good way forward.
Yes.
I'm talking about from disease and medical.
Right.
data.
But what I'm saying is, in terms of size, what you have in Garbh-Ini is already big. What Shankar Nethralaya has probably is already big. So there are large data sets which perhaps need not be combined. Maybe they are better analyzed separately. But we need to.
Heterogeneity with different.
Right.
Well, actually, it's yes and no. If you take stillbirth is like 1.6%, right? So, and if you start asking questions on other pregnancy outcomes like gestational diabetes, preeclampsia, we didn't design our study for those outcomes. So it's an yes and no. And for stillbirth, if you need to answer, really have a very good prediction model, the total number of stillbirths in our data set is 110. So
Good point. Yes. So I think.
But yeah, I agree that there are like large clinics and hospitals where data does exist. So for example, cancer hospital in Adia, they have data going back, like breast cancer data going back to 2003. Right? Every year, around 600 patients enrolled, all the treatment protocols digitized. So that is something that we are now starting to look at. So you have to find a very good clinical partner. One is Shinjini's group that we are successfully collaborating. There could be others. So I think data scientists need to find their local clinical partners and start engaging with them. And then that's the most important thing, because without engagement, you won't even know what they have. When we went there to this cardiac clinic, they showed us their data and said, wow, you've been like working with this for like so many years. What they simply want, their question is very simple. We have been giving these treatment protocols. Can you just help us classify which treatment works better for which kind of breast cancer? That's it. Very simple question. Harder to solve, but simple question. So I think that, and the data is enormous.
And I think probably every hospital has several research-minded doctors who really want to do this. I mean, and also those who might not want to, but everyone who came to this meeting actually wants to collaborate with data scientists, right? Whether it's
and I think the elephant in the room is the funding. So we need to figure out funding as well, because you can't hire data scientists cheap. Good data scientists cheap. Yeah.
I just want to say something. So I work at IISER at Bangalore Science and Technology Cluster, where it's a mandate to bring in a consortium-based projects. We manage consortium-based projects where we bring in different stakeholders there. Two main themes are health and mobility, where data sharing is always a problem. And when we bring in those people, three things that I've observed that they keep talking about. One is, do you have common guidelines that everybody can follow for data sharing? And that's one. Another is some of them are afraid to share data because they think we don't know what you might find out of it, and what if it gives us some negative shade, whatever you have found from our data that we are giving. And third is, we have been collecting so much of data for so long, and what's the benefit that I get out of it if I am sharing it with you? So these three I keep observing. I'm not a researcher. I mean, I'm a PhD, but I've not worked with data as such. But in the projects that I'm managing, I'm a project manager. So these are the things people talk about frequently.
So very, very relevant questions. What we've practiced, and I think some of the other groups I know have practiced, that you lay out the ground rules in the beginning. So egos have to be submerged. So which is what you're saying, no? And I think the big thing is that you have to have terms of reference of, like when we started Garbh-Ini, we laid down everything. We were dealing with a lot of big wigs, National Institute of Biomedical Genomics, National Regional Center for Biotechnology. And we people had never done studies like this. You know, we've done different kind of studies. So I think you just have to, data sharing can actually be handled very well if you ensure your partner or the collaborator that credit or the importance of their data, they will get enough, I mean, now with multiple first authors, multiple corresponding authors, in terms of publication, that problem gets sorted out. If it's a product which is going into the market, I think there's a lot of co-sharing. So it's just about dialogue and platforms. Really, honestly, I'm not trying to say it's a very small issue. It is a big issue, especially when you're dealing with, people who have been collecting that data for a long time, but can all be actually just with a lot of talking and clarifying the things at the beginning. We are done.
Probably. I was just wondering on a final note about the translation part. And there's something that Pradeep also brought up. You want to say something? No, you were repeating yourself from yesterday maybe, but she was emphasizing that, when we work with the data providers, in her case, it's epidemiology, but eventually we want to be able to benefit the people whose data we are collecting, right? So whether it is building a better ultrasound device or improving public health interventions. So many basic scientists are more interested in publications and not really, thinking of.
But we are validating all these tools that we've now developed. And the next year or two will be for validation and then a clinical deployment. So we have a pathway that we are moving on to see that these tools we've just been given funding for the validation. So
yes,
I
no,
think-
I was more like, how do we build this into future projects and into the framework of.
Yeah. I think it's from the question. You'll have to make your question that way and not let the question end with a publication. And I think this impact factor needs to be thrown away.
Of course, yeah.
I really feel it has to be a paper which is well read, well
Yes,
cited,
exactly.
well immersed with
Yeah, no, thanks, Rahul, for. Yeah, I think, no, I just want to echo what Dr. Shinjini said. It's about building that, the whole continuum, right? From the research question to actually use of whatever is the output, could be a model, could be anything, could whatever coming out of that research. But I think there is a need to understand the other side. Like, what I felt that it's not that basic scientists don't want to contribute. I think they want to contribute. But what might be happening is that because they are not interacting enough with this is an exceptional situation where Dr. Shinjini was able to bring together an exceptional group of collaborators. But quite often, these are very ad hoc, one-off kind of interactions. And I think unless you do it over a period of time, consistently, then you understand the value. But one way to do that, I mean, I don't know, there are no perfect solutions, is also that you as a basic scientist, rather than, which I said, don't ask for data. Don't come and have some area of research in your mind and actually go and see. Like, for instance, in this instance, they are collecting data from those patients in district hospital. We don't expect that, a data scientist knows, how to see a pregnant woman, but just be part of the whole exercise, because you then have a human touch, from where this is coming, why is it coming, and how it will be used. Because sometimes I feel in some of our interactions with people from mathematical side or data scientist side is that we feel that they lack empathy. Maybe it's not, maybe they have it, but it just doesn't come out in the interactions. And no, I'm being very honest, because I think this is a place where we should talk. And then it could sort of put off the clinical or a public health collaborator, because then they may think like, you are just coming, taking my data and going. Like, she exactly brought out this issue. This is very real issue. And you don't want to give your data. I can tell you, I have had situation where I have not given my data simply because I feel that the other person is not concerned about the real outcome. Like, as I told you all, I'm an implementation scientist, and I care when that information will be used to improve the care of patients or community at large. But if you are saying, look, I want to write a nice paper out of it, then it kind of puts you off. So I think it's also important that you build that relationship and you show that empathy. I mean, especially I'm telling it to all youngsters who are looking out for data. So I think it's not enough that you get data. It's important that you get the context right. You don't have to know everything about the field, but be part of it. Just go see what is happening. Just interact with those people from whom this data is coming. It will change the way you will look at those numbers. You have to remember there are, lives behind those numbers. And this quite often happened in COVID. I want to say this because a lot of models which were being done, they were done by people who have never been in that public health setting. Simply throwing a number, this many cases will come, that many cases will come. But you don't understand how data is getting collected, what is the meaning of that data, and then you are blindly using that data to extrapolate, and that's what led to so many confusions. We need more such interaction. I really want to thank Rahul and the whole team which has put together this sort of a program. It's just amazing that the kind of discussion we are having, I've never had it before. And I really hope more of these interactions and more projects like Garbh-Ini.
Which can then... One of the reasons for showing that movie was, our discussion was very important to show people how data is collected.
Absolutely,
So
absolutely.
Not to...
Right.
I completely agree.
Yeah. So I think both sides need to understand each other better And then I'm really hopeful that with the kind of talent is there in the country and even in this room, we'll be able to do very good clinical and public health.
So just to add, like, till we went to Gurgaon Civil Hospital, for us, that was just numerical values and categorical values. I used to say these are numerical variables, these are categorical variables to all my students. We went to Gurgaon Civil Hospital. She said, you come and see how the data is collected. And then we could put each data point to a woman. That completely changed the way we perceived and realized that how difficult each data point is, difficult to get that data. So I think you're very right. Data scientists, when they go to a clinician, say, we want some data to munch on, that pisses off the clinician, right? And that is the language data science should not use, because munching means you are here only to eat a chocolate, not contribute anything back, like, and they'll throw the wrapper away. So I think data science needs to be more empathetic to how the data is collected, what are the questions they are collecting it for, and how you can contribute to that question rather than bringing your own sort of theoretical framework to put that data into and sort of validate your toy models. So I think that's.
Okay, so I think, okay. We are kind of, okay, sure.
Yeah, thanks, ma'am. So I would like to add one more thing here. Like one of the most common problem, like what I have felt in the past 2 years of my PhD is like we are somewhere creating a negative competition. Like, and the negative competition I mean here, like we are bothering more about the papers and the journals, not about the scientific questions. Like as the ma'am quoted, like I'm going to some data source, I will fetch some data, and then I will try to formulate my question. The science needs, like I'm not a scientist, so I really don't have the right to comment on how science need to be done. But why I have felt like what I feel like, because India is one of the biggest country now in terms of population. So if we really train our students to think why science needs to be done, how science needs to be done, they will figure it out. If they have a motivation why science needs to be done, they'll figure it out. So we should somewhere throw the notion of the impact factor, paper, journals, and all those things. And students should think why they should do science or a research question in mind. So I would like to add this thing only.
So on that note, yeah, let's end and let's thank the Garbh-Ini team, Shinjini, Ram, Himanshu, and Koundi. And we'll break. And today is a special dinner, which is right here, same place as lunch, I think, or somewhere here.